Well, good afternoon, everyone, and welcome to Samaritan's Purse International Health Forum. I'm Dr. Lance Plyler. I'm the medical director of our disaster response unit here at Samaritan's Purse and host of our Samaritan's Purse International Health Forum webinar. We're delighted to have you here this afternoon. Today we're going to be discussing HIV management, but before we get started, I'd like to call on Beth Thompson to open up in a word of prayer.
Lord, we just thank you for this day, and we just pray that you would bless our time today and Dr. Thielman's presentation. Lord, help it to be a great learning experience, and we just look forward to hearing from you today through Dr. Thielman. Amen.
All right, very good. So as I said, today we're going to be presenting an update regarding HIV management. I want to alert everybody during the presentation, if you'll take note, there's your chat box. It's accessible to you, and I encourage you to utilize that to pose questions to Dr. Thielman during his presentation. We'll try and address those as they come. With that said, our speaker today, I'm very proud to introduce Dr. Nathan Thielman is a longtime friend of the ministry here at Samaritan's Purse. Dr. Thielman is Professor of Medicine and Global Health at Duke University. Dr. Thielman studied his undergraduate, or conducted his undergraduate work at Wheaton College, and thereafter went to medical school and internal medicine residency at Duke University. He then went on to do an ID fellowship at the University of Virginia. Dr. Thielman is board certified, of course, in infectious disease. And he is an active infectious disease and HIV clinician and researcher. He happens to be the program director for the Duke Global Health Residency and Fellowship Pathway. He has conducted HIV clinical trials both domestically and internationally. His current research through the Global Health, Duke Global Health Institute seeks to optimize HIV testing interventions for high-risk populations in the Kilimanjaro region of Tanzania. And so without further ado, I will turn it over to Dr. Thielman.
Thanks, Lance, and it's good to be here, and it'll be fun to try to talk about HIV. It's a new sort of venue for me to do this with a Google Hangout, but we've got a great tech team, and I'm looking forward to interacting with folks through this. So with that aside, maybe we can go ahead and start with the first slide. There we go. Are we good? Okay, there we go. Yeah. So there are so many things that we could talk about this afternoon with respect to HIV disease. It is an absolutely fascinating disease from so many perspectives, biologically, socially, even politically. But I whittled down my HIV slide pool from around 350 slides, and I updated a few others to include what I think is going to be the most relevant information for anyone involved in international health and or emergency relief work, and what everyone really should know about HIV that might come in contact with it even from the periphery. And I've structured this really to begin with the basic epidemiology and the natural history of the disease. So that's actually what I'm going to call the bad news. We'll do the bad news first, and then we'll get into the good news. And the good news really all derives from treatment and the phenomenal advances that have been made in HIV treatment really since 1987, but 1996 was kind of the big watershed year for highly active antiretroviral therapy. So we'll talk a lot about the good news, and you'll see the specific things that I want to touch on there. And then finally, just a little devotional thought. I want to end with the best news in all of that. So with that introduction, maybe I can have the next slide. And I don't really view this as bad news. This is just, it is what it is. This is a pretty up-to-date estimate of the number of people who live in the world. There are about 7.2 billion souls scattered around the globe. And to make a point in an upcoming slide, I've actually parsed out the proportion that reside in North America and Western Central Europe versus those who reside in Sub-Saharan Africa. And if I can have the next slide, and you can see here that roughly 37 million image bearers of God are estimated to be living with HIV disease. And that's somewhat astoundingly here. You see the proportion that reside in North America and Western and Central Europe, and that's about 7%, and about 70% reside in Sub-Saharan Africa. So just next slide, to just kind of make that point again, think about it, 13% of the world's population lives in Sub-Saharan Africa, but about 70% of the world's burden for HIV is in Sub-Saharan Africa. And why that is the case is another topic that we could spend hours and hours discussing. But suffice it at the moment to just make the point that this is a huge problem in Sub-Saharan Africa. But again, phenomenal advances have been made, and what's even more impressive is that now people are actually talking about the possibility that within a generation or two, we may be HIV-free in the world, even without a vaccine. And I'll show you some of the data in a few minutes that gets to that. So if I can have the next slide, let me just do some really, really kind of basic fundamental things that everybody needs to know about HIV. And I apologize if this is review for anyone, but it's really important to understand two main things here. One is the CD4 positive lymphocyte, and the other is HIV virus itself and how those two interact. Typically when someone acquires HIV, their CD4 count will decline over the next decade or so, and without any intervention, they'll typically be dead within 10 to 15 years. There are two fundamental things that we need to know first about the CD4 lymphocyte count. The CD4 cell is a type of white blood cell. It plays an essential role in the immune system. These are also known as T helper cells, and they're so named because their main role is to send signals to other cells in the immune system, which are then told, hey, you need to go destroy this virus or this bacterium or this parasite, this fungus. And without these CD4 cells kind of orchestrating what should be going on in your immune system, we succumb to a number of infections which otherwise we actually have no problem handling whatsoever. So the second fundamental thing to know is that once someone becomes infected with HIV, the virus preferentially attacks the CD4 cell. It then uses the cellular machinery within that cell to replicate and produce new viruses that then destroy the CD4 cell in the process. And let me just get the next slide. So clinically, we can measure that interaction by measuring HIV RNA levels or the viral load, and we can also measure the CD4 count. And understanding what these two measurements are for a given patient is critically important in understanding his or her risk for opportunistic infection and response to therapy as well. So it's useful to think of this relationship as somewhat analogous between speed and distance, or more specifically as illustrated here, the speed of this fancy red car in miles per hour traveling down the road, down I-40 from Durham towards the Tennessee state line. And if I'm traveling 90 miles per hour, I'll get to that state line, which is mile marker 0, much more quickly than if I'm traveling at 50 miles per hour. Well, so it is with viral load and CD4 count. If I have a very high viral load, say 500,000 or so, I'll get to a lower CD4 count, such as a CD4 count of 200, that is one of the definitions of AIDS. I'll get to that given CD4 count much more quickly if I have a high viral load than if I have a low viral load. So hang on to that concept, and we'll get back to it in a little bit. But first, I just want to throw out a question here, and I'm not anticipating any real-time responses. Let me just get the next slide, if you will, but just kind of chew on this one for a second, and then hopefully the answer will be apparent in a few minutes if you don't know the answer right away. So just think about this one for a second. Which of the following clinical clues is unlikely to be seen in a patient with advanced AIDS? So a dorsocervical fat pad, oral hairy leukoplakia, oral thrush, having papular pruritic eruptions, or wasting. And 4 of these are actually not terribly uncommon in someone with advanced AIDS. 1 of them would be uncommon. So just think about that. I'm actually studying for my ID boards again, so I'm kind of into thinking about these kind of questions. All right, let's go to the next question, or actually the next slide, rather. Yeah, so, oh, this is one of those slides that, okay, good. I'll need you to click through this pretty quickly for me. So this is really talking about the natural history of untreated HIV disease. And shown on the x-axis are just years since infection, and on the y-axis is the CD4 count. And a normal CD4 count is generally considered to be above 500 or so. In this instance, it's, say, around 900 or 1,000. And there'll be a decrease, a little dip down acutely when someone is infected with HIV virus. And parenthetically, at that time, the viral load is just sky high right at the time that someone becomes infected with HIV. And then over time, if you'll kind of click through now, the initial sorts of opportunistic infections and complications that one sees are bacterial pneumonias. And TB can occur at any point in the course of HIV infection. But later on, as the CD4 count declines, particularly less than 200, we'll start to see opportunistic infections such as pneumocystis carinii or Gerobaceae now, pneumonia, cryptosporidiosis, toxo, candida esophagitis, and the others listed here. And I'm actually going to spend a few minutes to go through some of the key ones here, and this interesting thing called papular pruritic eruption. So again, if you're thinking back to that question that we just gave you, actually the answer was dorsocervical fat pad. That's what you would be unlikely to see in someone who has advanced HIV disease. That actually can be a complication of protease inhibitor-based therapy. So if I can have the next slide, this is kind of where I actually have done a good bit of work over a decade at Kilimanjaro Christian Medical Center. Beautiful place to work with Mount Kilimanjaro in the background, as you can see there. And next slide. A number of years ago, we actually did a study. It was a very simple study. We actually just looked at the charts where they have a pretty good medical record system there, and looked at 1,200 individuals who were known to be HIV infected, who were admitted to the hospital there, and just looked at, okay, what other diagnoses are listed in their charts, and did they survive this hospitalization? And we got a reasonable picture of kind of what's going on in this population just with this simple study. And you can see that TB was the most prevalent condition that we found, with very high mortality rates. You can also see malaria, gastroenteritis, diarrhea, and then a lot of other kind of non-TB pulmonary complications. Next slide, please. And other studies have shown similar work. So Tanzania, of course, is in East Africa and West Africa. The causes are really not that different. Frankly, this study was a better study than the one that we conducted, because they actually had autopsy data to definitively establish a number of these diagnoses. But again, you can see that TB is high up on the list. Bacteremia was quite high. Toxoplasmosis, I'll show you something to consider with toxo in just a few moments here. And then the list goes on. Next slide. So while there doesn't seem to be a lot of variation in terms of HIV-associated conditions within sub-Saharan Africa, there is a good bit of variability across the globe, as highlighted here by continent. TB, of course, is going to be highly prevalent in resource-poor settings in Africa, South America, and Asia. We tend to see a little bit more PCP here, pneumocystis pneumonia, in Europe and in the U.S. than we've seen in African studies. We see a lot of HIV wasting. We used to call it slim disease in Africa, so that's highlighted there for you. And again, don't see a lot of CMV that we know about. CMV is cytomegalovirus in sub-Saharan Africa. I do think we're going to see more lymphoma over time as more people are living longer with HIV. So if I can get the next slide, TB is an incredibly important thing to know about. Globally, it's the most common complication, and it's really important to note that patients with HIV will present differently with TB, particularly later in their course of illness. So if they have a lower CD4 count, they're much more likely to present with atypical TB. That means more extrapulmonary disease. They may not have kind of the typical cavitation that is seen. It can be more widely disseminated. I think I'll show you a slide in just a minute that actually shows when you just do blood cultures that include mycobacterial blood cultures in sub-Saharan Africa among patients with HIV, you actually see a lot of TB bacteremia in these patients, so it can be widely disseminated. So if I can get the next slide. And then this is just a TB that's shown a relatively typical case. You can see upper zone cavitation and some consolidation there. There's some pleural thickening and blunting of the right costophrenic angle. And in the left lung here is completely normal. Some of the other pulmonary disorders that we need to be on the lookout for in the next slide. Yeah, so again, bacteremic pneumonias can be seen more in patients with HIV. Again, even at higher CD4 counts, which I think is interesting. It's a really good reason to remember pneumococcal vaccination in patients with HIV. And then later on, you can see some of the other pulmonary disorders, things like pneumocystis and nocardia. Again, a lot of pneumococcal pneumonia is seen in HIV-infected patients as well. Legionella, TB we've already talked about. Haemophilus influenza would certainly be on the list as well. If I can have the next slide, this just shows you a typical sort of lobar pneumonia that would be seen in someone that has Streptococcus pneumoniae, for instance. On the other image here, you can see more of an interstitial pattern that shows the shadowing there of the interstitium on the vascular markings. There's no lymphadenopathy. You don't see any pleural effusions. And that's fairly characteristic of pneumocystis. And just, again, some clinical and radiographic clues to think about there. Next slide, please. And here again just highlights, I think there are 2 points of this to make note of. One is that TB bacteremia is real. You can see this in this study from Malawi, that an astounding number, frankly, of patients, actually you can pick up TB in their blood. You've got to have the right sort of culture medium to do this. Of course, it won't grow with just routine blood cultures, but it is a significant cause of bacteremia in sub-Saharan Africa. And then you can see the seasonality of non-typhi salmonella infections and of pneumococcal disease as well, and cryptococcus, which those of us in the U.S. who take care of HIV-infected patients are familiar with. We see a good bit. Well, it's quite prevalent in sub-Saharan Africa as well. So let's just kind of wrap up the clinical manifestations of HIV with the next slide and quick look at CNS disease. Most of the CNS disease that you're going to see with HIV is going to be relatively late stage. And the big ones to think about are toxoplasmosis, cryptococcal meningitis, CNS lymphoma, and then HIV dementia. If I could have the next slide then. And yeah, here what you see is a CT scan that shows a single mass lesion here on the large, it's kind of large, it's on the right frontal cortex, it's enhancing, and there's quite a bit of edema and mass effect shown here, and that's a pretty typical lesion for either toxoplasmosis or CNS lymphoma. And you really can't radiographically distinguish between the two. And so it can be a little bit tricky to try to sort that out. If it's toxo, then you can treat that pretty easily with pyrimethamine and sulfadiazine. If it's CNS lymphoma, it's going to be more problematic for sure, depending on what resources you have available. And so often one will kind of start out treating empirically for toxo and watch very closely. If they don't improve, then you might do a biopsy. If you can do that, it just kind of depends on your circumstance. If you have access to serologies and can look for antibody to Toxoplasma gondii, that can also kind of help sort this out. But it's an important conundrum that can be faced clearly in resource-poor settings as well. So next slide. This is a woman I saw in Tanzania a few years ago with late-stage HIV disease. You know, at first I thought she had been beaten. It looks like bruises, which tragically is not an unlikely possibility for a number of women. But especially because of that linear lesion up on the right shoulder area. But when you actually looked at it more closely, what you saw is that these are raised and they're quite purplish in nature, and you can see the dissemination about her face. And this is Kaposi sarcoma that is seen in someone with late-stage HIV. Next slide, I just want to show you a couple of other kind of manifestations of late-stage HIV. This is the oral mucosa, and if you took a Q-tip and you swabbed this, you would be able to kind of remove some of these pseudomembranes. And so this is thrush. And if you have thrush and adenophagia, difficulty swallowing, and thrush, then next slide, for all purposes practically, you need to think that this is Candida esophagitis until proven otherwise. Thrush plus difficulty swallowing. You treat them with fluconazole, it should get better. If it doesn't, then you're going to have to rethink the diagnosis. But it's nice to not have to scope someone, at least initially. Next slide. Another important manifestation, and this was actually reflected in the question, is pruritic papular eruptions. It's very interesting sort of thing that we see a little bit of here, but it's not nearly as prevalent as it is in sub-Saharan Africa. These are typically firm, discrete, initially erythematous and maybe even urticarial papules that are highly concentrated, especially on the extremities, but then sometimes, as is depicted in figure B there, it can be on the trunk, and it can also, for that matter, be on the face. And they're pretty itchy, and you can see it in late HIV infection. And it's interesting because there's actually some data to suggest that this may actually be kind of this exuberant, dysregulated response to arthropods, so like mosquito bites and such, although it's a little bit hard to think that that's what was going on in this guy's back. But when you see it primarily on the extremities, at least there's a nice paper in JAMA that made that assertion with a reasonable body of evidence. So, but be on the lookout for it, because it is actually quite common in sub-Saharan Africa and can be one of those clinical clues when you're actually just seeing somebody and you don't know if they're HIV infected or not. This could give you a clue as to whether or not they have advanced disease. So let's just hit this concept. Well, next slide one more time. Just kind of scroll through these. There we go. Yeah, keep going. Yep. Yeah, so this is just kind of what we were saying, and just to kind of review that, hopefully kind of fix it in your head. These are the key sort of complications of HIV disease that we ought to be thinking about. Next slide. The net effect of this is kind of depressing, actually, when you think about it. And this is kind of a slide that comes from the U.S. Census Bureau. If you want to just focus in on one thing there, focus in on Tanzania. And this is just based on 2012 population data. Essentially, 7% of their population in Tanzania is missing because of HIV disease. That's essentially equivalent to the population of the state of Iowa. So it's, you know, that's a pretty astounding sort of figure when you think about it on a global scale, that this virus is responsible for wiping out 7% of the population. So next slide. So that's all the bad news. Now I want to give you the good news. So here's the really cool thing. This is a patient that I saw a number of years ago domestically. And he presented to me with a very low CD4 count, a CD4 count of 33, and a viral load that was over 1 million. So he had advanced HIV disease. And what else do you see here? Well, the first thing you'll notice is he's got these little spots all over him. And this is Kaposi's sarcoma. It's not quite as purplish in hue as we saw in the woman from Tanzania, but it's the same entity. You'll also notice he has on the right side of his neck this huge mass. And I actually biopsied this. I thought, is it Bartonella? Is it MAC? I don't know. I treated him empirically, but without any definitive diagnosis. I treated him for MAC, but I don't really think that's what it was. And eventually I stopped giving him that, and I just gave him antiretroviral therapy. And next slide. And this is what he looked like 8 months later. I don't even know what that was on the right side of his neck. I had no definitive diagnosis, but it melted away with antiretroviral therapy. And with restoration of his immune deficit, his CD4 count goes from 33 to 285. His viral load is below the limits of detection. And you can also see when you look at his Kaposi sarcoma, those lesions as well are just melting away. And that is what is so amazing about these drugs. Let me just hit the next slide here and tell you a couple of things that I think are really important principles of HIV care. So I remember I was a medical student when AZT was approved and when this study came out. And it was pretty, this was like earth-shattering, because AZT was shown to reduce death and also opportunistic infections when compared to placebo. And so this was, you know, amazing news. We had nothing going on at that time. And this was a rigorously conducted clinical trial. The evidence was quite compelling. But look at the next slide here. What was really going on here, and we actually didn't know this at the time because we couldn't measure viral loads at the time, is that the benefit that we saw was because we saw this slight drop in viral load, but it actually then kind of rebounds over time. And it's not fully suppressive. You know, we got a little bit of immunity back, and so it kept people alive for a short period of time, the period of time covered by the study, but ultimately that's not going to save somebody from dying from HIV. If you can click the next slide. But what does is if you can actually suppress the viral load all the way to undetectable. And so it was really about 7 years later that combination therapy with 2 drugs could be achieved, and you can see that the viral load went down even further, about a log reduction. And then 1996, again, that was really the watershed year in HIV treatment, because when we combined 3 different drugs, we were able to suppress the virus below the limits of detection and sustain virologic suppression. And in that setting, you can affect immune recovery that will be sustained for a long, long time. So next slide. This is kind of just to tell you, this is what's out there. There are 27 different drugs that are now available to treat HIV in multiple different classes, as you can see here. There are 4 single tablet regimens. So that is to say, you can take 1 pill once a day to treat your HIV. And there are 4 different options that are available for you now. So it's a pretty remarkable advance has been made in treating this disease over the years. Next slide, please. And what's even more encouraging is that this is not just something for wealthy nations. And this is largely because of President George Bush. And I remember watching the State of the Union speech. I remember where I was sitting on the couch when he announced PEPFAR, and I thought, oh my word, this is amazing. And I thought also what a wonderful testimony it was just to the world and because of his faith. And so here's the latest figure I could just kind of pull up searching around, that 7.7 million people are receiving antiretroviral therapy as of 2014 because of PEPFAR. Really, really remarkable game changer. Next slide. And this is even more evidence for how impressive that is. When you look at the proportion of the populations that are HIV infected and are actually on antiretroviral therapy, you can see that sub-Saharan Africa is actually doing really, really well. And this was not predicted prior to PEPFAR. There were a lot of skeptics out there back in the day that, well, you really couldn't do this in Africa, and they were absolutely dead wrong. Next slide. This is actually hot off the press. The WHO has just updated their guidelines. And it used to be that we said, well, if your CD4 count is less than 200, that's when you should start antiretroviral therapy. And then we said, no, if your CD4 count is less than 350, that's when you should start antiretroviral therapy. And now, as of September, which is when these guidelines just came out, the WHO is saying that everyone should be offered antiretroviral therapy. And that's actually going to take quite a bit of resources to actually expand that. But I want to tell you why that's the case in maybe the next slides. Let's only have the next slide. Yeah, so there are two, I won't go too nerdy with you on these studies, but I think they're pretty compelling studies, and a little bit of science here I think is really helpful, because the evidence base for this recommendation that everyone should be on antiretroviral therapy, I think, is incontrovertible. This is a study called HPTN-052. It was the HIV Prevention Trials Network, and they actually took serodiscordant couples. That is to say, when you take one partner who's HIV infected and one partner who is not HIV infected, and then you treat that HIV infected partner, and you want to look at how they're doing, etc. But they also wanted to look at rates of transmission to the uninfected partner. And they randomized to either early or deferred therapy based on CD4 count, and that enabled them to do an analysis to demonstrate if starting antiretroviral therapy earlier could reduce transmission. And shown there in red is a phenomenal statistic that there was a 96% reduction in transmission of HIV from the infected to the uninfected partner when that infected partner got put on antiretroviral therapy. Next slide. And that's just illustrated here when they actually went through and actually looked at the data, and genetically they could tell if this was the same virus, that someone got HIV from the partner, or was there, did they have an extra partner relationship going on. And of the 28 linked transmissions, 27 of them occurred in the delayed arm versus 1 in the immediate arm, meaning those in the delayed arm weren't receiving antiretroviral therapy. So that's where we get that the compelling data. So there's a real public health benefit to identifying someone as being HIV infected and starting them on therapy right away. So that's point one. Next slide. And this was a huge big deal. Science was saying, this is the breakthrough of the year. People are talking again, could this be the end of AIDS? Because again, if you can test and treat an entire population and get them on antiretroviral therapy, you could essentially wipe away the epidemic if you could do those things well enough. Next slide. Also, very importantly, we're not just talking about public health here. We're talking about individuals. And the START study is to say that recently just kind of wrapped up. We were a site here at Duke. There were many, many sites around the world, 35 countries, and it randomized people who were HIV infected to either starting antiretroviral therapy right away or, again, delaying at this point to a CD4 count of less than 350. And in this study, the key endpoints were, are they having serious AIDS events? Are they dying? And it wasn't about transmission to uninfected people. It was just, how is the individual doing? And what you can see here is that the risk of serious illness or death was reduced by 53% for those who were randomized to receive immediate therapy. And there are some other studies now that have come out along these lines, but these are really two pivotal studies that influence our recommendation that everybody who has HIV disease, regardless of their CD4 count, should be started on antiretroviral therapy. So next slide. So what do you start? And I'm not going to get too far into the weeds on this because this actually takes a good bit of thought. But these are the WHO guidelines for what you could think about starting. Tenofovir and lamivudine or efavirenz is a very good regimen. In many areas of the world, this is available. It's one of those single tablet regimens that's a fixed dose combination. And you can see a number of alternative first-line regimens there. Again, if anyone wants to go deeper in this, the resources are out there. The WHO has a lot of good information that you can access. Okay, let me do another question here. I hope this should be, let's get the next slide up. Yeah, thank you. The two most important laboratory tests to characterize HIV infection in a patient in the tropics are, and you can see the choices here, CD4 count and eosinophil count, viral load and sed rate, total lymphocyte count and TB quantiferon gold, CD4 count and viral load, or a full blood panel, as they sometimes call it in East Africa, and a viral load. So yeah, think about that just for a second. I won't wait for any responses, but just kind of think about that. And then here's really the answer. How you monitor, let's get the next slide. It's really best to monitor with viral load and CD4. Now, viral load measurements are kind of tricky. Real-time PCR, can't do this everywhere. It's quite expensive. And there are a number of studies out there that are kind of looking at the cost effectiveness of viral load monitoring in resource-limited settings. And it's not entirely clear. It makes me, frankly, very nervous to kind of be flying blind, if you will, and to not know a given patient's viral load when they're on antiretroviral therapy. If you can't do that, then a CD4 count is the next best thing. And kind of the worst thing is to just do clinical monitoring where, wow, this patient is starting to get sick again, and oh, they have a new AIDS-related complication. That's actually not a good scenario. So you really, minimally, you need to have CD4 monitoring. And if you can have viral load monitoring, that's even better. Let's do the next slide. What about prophylaxis? Many of you will know that we commonly prescribe trimethoprim sulfamethoxazole, or cotrimoxazole, as it tends to be known in other parts of the world, to prevent primarily pneumocystis pneumonia in patients in this country. I pointed out earlier, we don't see a lot of pneumocystis in sub-Saharan Africa, but a number of studies have been done that have demonstrated there is tremendous benefit to actually taking cotrimoxazole prophylaxis in patients with severe or advanced HIV disease in these settings, and particularly where malaria and severe bacterial infections are prevalent, or if someone is TB infected, they need to be on trimethoprim sulfa prophylaxis regardless of their CD4 count. Next slide. Just a quick word about HIV and TB. There are two really important points that need to be made here. One is, many of us have heard of this phenomenon called immune reconstitution inflammatory syndrome. And what happens is that if someone has an opportunistic infection, particularly a mycobacterial infection, a TB infection, and you put them on antiretroviral therapy, then all of a sudden the CD4 count starts to come up. And as the CD4 count comes up, these CD4 cells say, oh, aha, there's this infection over here with TB. Let's go do our inflammatory thing on this infection. And you can get this very kind of exuberant inflammatory response that actually can be kind of harmful in the patient. And so a number of us, when we were in these circumstances, were thinking, well, golly, if someone comes in and they've got HIV and TB, should I defer therapy and treat the TB first and then start them on antiretroviral therapy, or should I just start them on both at the same time? And we actually did a study on this in Tanzania a number of years ago. Ours was underpowered. We only had like 70 patients in our study, but a much better, larger study was done in South Africa subsequently that demonstrated conclusively that really in patients, even if they have a very low CD4 count, actually especially if they have a low CD4 count, you should go ahead and start them on TB therapy and antiretroviral therapy then 2 weeks later. You don't want to actually start them on 7 new medicines at once. That seems like a bit of overkill just kind of clinically, because if they develop a rash, which drug is doing it, right? So it makes sense to say, okay, let's start them on anti-TB therapy, wait a couple of weeks, and then start them on antiretroviral therapy. But don't delay any longer than that. So that's point one. And then point two is that there's a lot of concern about drug interactions, particularly with rifampin. And actually, if you look at the pharmacokinetic data, you would be actually quite concerned about the interaction with efavirenz, a very commonly prescribed antiretroviral, and rifampin. But the good news is that a lot of clinical data is available now that shows that this actually works. And actually, that's a preferred regimen, is to be on an efavirenz-based antiretroviral therapy and rifampin, and that way you're really giving the best of both worlds for HIV and TB. So 2 key points. The CDC document that's relatively recent very nicely outlines these 2 issues and a number of others. Next slide. So, given all of this, why do some people fail antiretroviral therapy? And I'm going to throw a trick question at you here. Next slide. This is actually, I think, a pretty important question. So, say you're caring for patients in a new refugee camp just outside of a conflict zone in Central Africa. Samaritan's Purse has placed you there, and someone comes to you, a 45-year-old HIV-infected refugee who has been 100% adherent to their tenofovir, emtricitabine, efavirenz regimen, and they've only got 7 tablets remaining. And so then you consult your logistics and supply liaison, and he says, you know what, there is actually no reasonable possibility that we can resupply this patient's antiretroviral therapies. They are going to be without. So what are you going to advise this patient to do? So should they take 1 tablet every 3rd day? Should they just kind of extend it out? Should they continue to take 1 tablet daily until the supply is exhausted? Should you cut the tablets into 1/3 and take 1/3 of a tablet daily? Should you just stop antiretroviral therapy and then if they get sick, restart it? Or should you refer them to drink tea that's brewed from the root of the mugariga tree? So yeah, think about that one. And I'm going to actually tell you now what I think the answer should be. Actually, no, I'll tell you after we look at this slide. Look at the next slide, will you? There we go. Thank you. So remember back to that when we were showing you the 2-drug therapy, and it was kind of suboptimal, so the viral load goes down and then it starts to creep back up. And what's happening is that during this period of time, the virus becomes resistant. So in this scheme, the resistant virus is red, and wild-type virus that's sensitive to all antiretrovirals is blue. Next slide. And then what happens over time is that you're just going to, if you continue this suboptimal regimen, then you're going to just see increasing viral resistance over time. So now think about our patient, what are you going to do with this guy? And I actually think the right answer is to say, okay, take your drug for the rest of the week and then stop. And then, hopefully, maybe something will happen and you can get drugs before the week is out, and you should make every effort to do that. But it's actually better to just stop antiretrovirals cold turkey than to take a suboptimal dose. That is exactly how you breed resistant virus. And if you stop it cold turkey, then you're much less likely to kind of breed resistant virus. Now, some people would say, well, because efavirenz has a longer half-life, you ought to cover the tail of the efavirenz with a little bit of tenofovir for a couple of extra days. I don't think you could do that in this circumstance, and I don't want to get into that nuance. But the bottom line is, it's actually, in this instance, it would be better to actually stop antiretroviral therapy altogether than to try to somehow take a third of a tablet every day or 1 tablet every 3 days. Next slide. And so this is, I'm going to just wrap up with a couple of final points here. One is, this is a fellow that I got to know a number of years ago, and he's actually now dead. He had HIV. He was 14 years old when we diagnosed him through some of the HIV testing work that we were doing. You can see he has a little bit of scarring around the left eye rather, and a little bit of opacification there, and that's because he had zoster ophthalmicus. We actually got him on antiretroviral therapy. He took it for a while, and then he kind of quit. And it's very sad to me. I don't know why he stopped taking his medicines. He was kind of doing the teenager thing, I think, was kind of part of it. But it's really tragic. And if I can have the next slide, there are a lot of there's a lot of things that kind of wrap around the notion of adherence to any medication. And it's how people trust their provider. Are they involved with cocaine or alcohol use or coping issues, or are there are lots of things. Are they mentally ill? There are lots of things that influence the way that someone interacts with the healthcare system and whether or not they're going to take their medicines. And that's actually, again, that could be a whole other lecture. But I think it gets to the point that you really want to try to understand what makes people tick, and also to understand, let me have the next slide, the critical importance of stigma in this population. And when you think about it, there are very few diseases that we deal with that are so stigmatizing as HIV. And when you're trying to kind of hide your pills from your family, you're more likely to miss doses. And so we did a study at KCMC a number of years ago where we just looked at, kind of looking at a lot of different variables. What were some of the key predictors for someone failing their antiretroviral regimen? And one of the key predictors that came out of this analysis was lack of disclosure for their HIV infection. So that is to say that if they actually told somebody about their HIV infection, which means they were probably less stigmatized and they kind of had some support from somebody, that they actually did better in terms of virologic outcomes. And I think that's an important message, and also something that just kind of, I think, because we're people of faith, the gospel has something to kind of speak into this and how we treat people who are stigmatized, because sin is stigmatizing, and there's an answer to that. Okay, last concept. If we can just do the next slide. I'm going to skip the question here just in the interest of time and go straight to what I want to mention to this group. The next slide, please. Yeah, and that is a healthcare worker post-exposure prophylaxis. So just thinking about what is it that some people who are kind of not doing HIV care, but you might be involved in emergency response work, and you might get stuck by a needle. What do you do about that? And I think this slide actually summarizes it pretty nicely. The first thing that you should know is even with a percutaneous needle stick injury from someone who is known to be HIV infected, your risk of acquiring HIV is estimated to be about 0.3%. So that's actually pretty low. So the odds are kind of in your favor, which is good. I mean, it's still a very disturbing kind of circumstance, and I've been in that circumstance where you've been stuck with a needle and actually had to take antiretroviral therapy for a while, and you know it's no fun. But the good news is you can make that risk of 0.3% go much lower if you start antiretroviral therapy immediately and take it for 4 weeks. So don't forget about post-exposure prophylaxis. Some of the modifying factors there are the sharp type. If it's a hollow bore needle, it's a higher risk injury. You know, if the patient has a much higher viral load, then also, you know, it's a higher risk injury as well. The next slide just kind of outlines some things that are important to document. You want to actually document HIV status of the source person. You want to initiate post-exposure prophylaxis as early as possible, ideally well less than 72 hours after exposure. And remember that it's not just a needle stick, that splash of kind of body fluids to mucous membranes are also constitutes an exposure risk. And then actually what to use, next slide, I've never quite understood, next slide, yeah, I've never quite understood, whoops, sorry, the previous slide. I've never quite understood the notion of just give 2 drugs. And the WHO says, well, 2 drugs is effective, but 3 drugs are preferred. And I really, like, I'm a 3-drug person. Like, if you're going to go after this, go after it. If someone has some side effects, you know, and you need to back off to 2, okay, so be it. But I would start with 3 if you're gonna do this. And there are a number of different ways you can do this. Tenofovir plus lamivudine, or emtricitabine for that matter, plus a number of the other drugs here are all kind of recommended first-line ways of doing it. Don't just pick any drug. I will say there have been some adverse effects when people have taken nevirapine for this. So you don't want to, you want to give this some thought, take a look at the guidelines, call me. I mean, this is an important thing that you want to get right. And then you can see the duration there and the follow-up serologies that should be done. And again, you want to encourage people to take every tablet. Okay, so next slide. So that was kind of a whirlwind, but we tried to kind of take you through the bad news to the good news about antiretroviral therapy and what it can achieve even with post-exposure prophylaxis. But I don't get to end many talks like this, but I want to just talk about the best news. And I've actually, if I can have the next slide, you know, it's interesting to me that a lot of us in the HIV world, particularly those who are taking care of patients with HIV prior to 1996 and around that time, witnessed what a lot of people called the Lazarus effect. It was really remarkable. I mean, people deathly ill, they get put on antiretroviral therapy, and their lives are restored, and they're living well, doing well now. And, you know, okay, Lazarus effect. Okay, think about Lazarus. Okay, Lazarus died, as did every other person that Jesus healed, and as will you and me. So Lazarus was raised from the dead once, but then he died. And you and I are going to die, and everyone we seek to treat in our medical practice is someday going to die. So the really good news, which I assume and hope is not foreign to anyone listening to this talk, is that there is hope beyond the grave. And that this is because of the person and work of Jesus Christ, and that He cares about every single one of the 7.2 billion people in the world, including the 30-some-odd million that are HIV infected, and that nothing, that once we commit our lives to Him, that nothing can separate us from His love. You know, Paul says, neither life nor death, nor angels, nor rulers, nor things present, nor things to come, nor powers, nor height nor depth, nor anything else in all creation can separate us from the love of Christ. And one thing that I've actually been thinking about some, and I think we all have to be careful kind of how we do this, is writing scripture prescriptions for patients, the right patient. I wrote out for someone the other day, Psalm 139, take 3 times a day. And you know, he clearly needs to take his antiretroviral therapy, and that's a part of it. But I don't want to neglect the other part of it, which is the really, really good news, and that is that there's hope beyond the grave. So with that, I think we got a few minutes, Lance.
Well, Dr. Thielman, that was a phenomenal presentation. You did an excellent job of updating us with regard to therapy and providing an overview to some of us that aren't directly involved with treatment of patients with HIV on a daily basis. But I'd like to reach out to our listening audience. Dr. Thielman is available for questions at this point, so if you could just type in your chat box any questions you want to pose to Dr. Thielman, and we'd like to entertain those. While we're waiting there, Dr. Thielman, I just want to maybe just sort of summarize some of the things you said, but I concur with you. I mean, it really is just amazing what treatment has provided for these persons. We're about the same age, and I remember at one point, I think especially for people in the developing world, this was an automatic death sentence. And PEPFAR is just amazing. You know, we should be very, very thankful, I think, to the Bush administration and President Bush for implementing this program that has extended care to so many millions of people in the developing world. And it really is amazing to see, like you said, to see these opportunistic infections just melt away with the advent of therapy. So I think also the challenge is before us with regard now with the new guidelines from WHO in September, regardless of CD4 count now that we should implement ART therapy, and that's certainly going to be a daunting task before us. But I think it's it's certainly good as the studies validate. And then lastly, we have some question. I have a question for you, but I think you're right, Dr. Thielman, that there's so much stigma, for these patients, and to get them to overcome some of these stigmas and really get engaged with therapy and have that social support network, and as physicians we can support them. I fully support what you said about, in fact, I used to give prescriptions with Bible verses on them, so I think that's a great idea. But Dr. Thielman, let me pose a question to you. It says, do you have any thoughts regarding PrEP from a Christian perspective? Seems to still have some controversy around it. Would you encourage PrEP in international scenarios?
That's a really good question, and I've been thinking about it a lot. I was selective in what I presented here, but also included in the September 2015 guidelines from the WHO is the recommendation for PrEP, and PrEP is pre-exposure prophylaxis. So we talked about post-exposure prophylaxis. So after you're stuck with a needle or otherwise exposed to HIV, can you take therapy and decrease chance of transmission? So the other question is, if someone is at high risk for acquiring HIV, can you actually put them on antiretroviral therapy, a limited dose? And the studies are primarily with tenofovir or tenofovir combined with emtricitabine. And the data is pretty clear that if you actually take antiretroviral therapy at a lower dose and with fewer pills, or with fewer pills, you can prevent the acquisition of HIV. So I think probably at the heart of that question is, well, does this kind of disinhibit risk behaviors? And that's a tricky one, and I've wrestled with it. I've actually talked to some of my colleagues who aren't in medicine about it as well. Mm-hmm. And I view it as this way, that we actually should prescribe PrEP when it's indicated. The WHO says that it's indicated in someone that has essentially about a 3% chance per year of acquiring HIV disease. So this is pretty high-risk behaviors. Mm-hmm. And I think as a Christian, the Christian perspective, there's a public health perspective to it as well, but the Christian perspective as well is that, you know, if someone's dead from HIV, it's pretty hard to share the gospel with them. And I think I'm gonna err on the side of keeping them alive and praying that the Lord will help open up doors so that they can come to know Him.
Well, thank you so much, Dr. Thielman. Again, that was an excellent presentation, and I just want to thank our audience for participating today. I want to remind you about our CME. There is also, if you'll note with the email, there's an extra step. Make sure that in addition to submitting your questions, that you submit us your name and date, so that we can ensure that you receive credit for your CME. Also, if I just want to highlight, if you'll see on the email that we sent out for this webinar, that we are developing our international disaster response field hospital, and we have DART training, which is preparation for participating with Samaritan's Purse in disaster response. So if you're interested in that, please tap onto that application so that you can get involved. And finally, I just want to close by saying that next month we will again have our next International Health Forum. We will be sending out an announcement specifically with the date and time and speaker with that. And with that, we will conclude. But thank you so much for joining us. And again, Dr. Thielman, many thanks for an excellent presentation.
Thank you.